he presented about 4 months back in our institute. He had history of aortic valve replacement about 1.5 years back. This time he presented with the progressive respiratory difficulty while lying and dyspnea regression. On examination, he was quite stable. All the parameters was normal, but there was a pulsatile chest swelling that was involving the mid and upper part of the chest. His X-ray test was done, which showed clear-cut medial mediastinum widening, upper and middle part of the mediastinum was widened, and metallic aortic valve perception inside. His echocardiography view, which got available in a modified view, that showed the aortic valve was working normally, and there was an aneurysmal pouch, that was a huge cavity that was anterior to the ascending aorta. There was a to-and-fro flow from the rent, which was near innominate artery. So we did CT angiography, and that showed that the upper mediastinum and middle mediastinum mass was there, but the CT report was showing that there is a pseudoaneurysm of left internal memory artery. So we decided to catheterize the patient because it was very difficult to assess on these findings. So to get a true picture, we catheterized the patient. Left analysis was taken, and then left innominate artery angiogram showed there was no any aneurysm. Then we did right innominate artery angiogram, that was also very clear. There was no aneurysm. We did ascending aortogram, that showed a rent in the base of the innominate artery and the upper part of the ascending aorta. That measured 4.87 millimeters. So the patient was taken back to the ward, and we thought, what should we do? We discussed the case with the cardiac surgeon, and it was huge swelling. It was about 11 into 10 centimeter, and it was bulging through the chest. There was a clear flow from ascending aorta at the base of innominate artery to the anterior chest that was involving all the anterior chest. We crossed this defect by taking tegomoglide wire and had assessed the 5-GL4. After assessing, we did angiogram that showed a very huge aneurysmal dilatation, aneurysmal cavity. So, as we had discussed with the surgeon, he advised that we should have assessed from the chest tube to get a safe, squaring the aneurysm. So we passed the femoral sheath from the anterior chest to reassess and put a 6-inch femoral sheath. After that, we took the pneumo wire, and the pneumo wire, we had a good loop in the aneurysm, and you can see metallic aorta type 2 and wire is there. We decided to uproot this defect, but options were very different. Like we had choice of PD device, we had a choice of DSC device, we had a choice of MFO device. So we took the MFO 10-8 device. Rib sheets, 5 cm sheets was taken into the aneurysm, and check angiograms were done in the same time. So we took 10-8 MFO for our device, and all the assembly was pulled back. In the meantime, we had check angiograms and put the device across the defect. So through the sheath, we checked this aneurysm, and there was a huge collection of the blood. In the meantime, we saw that there is no residual leak. This is the final angiogram before we release the device. So we did the echocardiography after putting the device. That was showing a huge amount of blood in it. So we sucked that blood through the sheath. About 500 ml of blood was sucked, taken back, and then checked if there is any clot. Till the clot appeared, we stopped, and echocardiography showed it was a good position device with no residual leak. This was the initial X-ray, and this is the 3 months follow-up excisions of that patient. That showed clearly disappearance of the mass, and patient is alright. He was taken to ICU after procedure. First thing suture was applied at the sheath, and we removed the sheath, shifted to ICU, then